we're here at the IMWG meeting in Austria in 2021, and we've just completed a debate session where I had the pleasure of debating the role of targeted therapy and molecular segmentation with my wife, the great Dr. Davies. It was a really good session, and I think there was no winners, no losers in this session, and we came up with some very good conclusions, which is we're there and thereabout for applying molecular segmentation and targeted therapy. This is really going to move the field forward, and if I believe what she says, I still have a bit of work to do.
So interesting, I was asked to do the negative side to segmenting patients and delivering targeted therapy. And it was quite useful because I've thought about this for a long time, and so I was able to provide some kind of guidance, I guess, for what I really need to know before I'm happy to move forward. So I was actually suggesting to Gareth that yes, we have our groups currently. We know that extramedullary disease, plasma cell leukemia, the RISS stage 3 patients are all performing badly. But we need to refine that a little bit and to add in a little bit more detail about 17p and 1q. So we need to know the percentages of cells which need to be positive to put those patients into the high risk group. We need to know a little bit more about gain and amplification, and we need to know a little bit more about the mutation status, particularly of 17p. And so I was actually suggesting to Gareth that all of that data is there, and if we can accumulate it and put it all together, then we'll have those answers hopefully in the next 6 months, and we can really start to move forward with these strategized clinical trials.
So the interesting thing is that the theme of it was really important, and I think the theme of the debate at the end was about consensus. The yes and the no side to this debate is exactly in the same place. It's more around not should we start doing stratification now, it's more around exactly how do we do it and how do we make it more accurate going forward. And so the fact that there are 5 or 6 trials already planned for high-risk patients, the success of venetoclax in 11-14 patients, means we are really doing it. And the difference between both sides of the debate was very minimal, really. It was, yeah, we have work to do to make this even better, but now's the time to start.
Yeah, and I think the interesting thing was maybe prior to the last year or so, it's been a great idea and we've been collecting the data, but we've maybe not had the drugs and the instruments to actually put it into practice. And now we have a really good set of drugs, including the new ones such as the bispecifics and the CAR T cells. You can actually begin to say, hey, okay, there are a group of poor performing patients. We know they still perform poorly even with those new treatments. Let's try and be a little bit kind of innovative, and rather than knowing that they're going to have a PFS with our current strategies, let's try and use some of these new treatments we've got to really make a difference for those patients.
So yeah, importantly, Dr. Einsler followed on from our discussion and debated the role of bispecifics, and he made a really strong case for the use of bispecific T-cell engagers. And we have a clinical trial that we're planning where we put talquetamab, a GPRC5D T-cell engager, post-autologous stem cell transplant. And the importance of this as a study is these things really start to talk to the value of cure, long-term survival, and moving the whole field forward.
Yeah, and it's not just the bispecifics, is it? A number of the companies are using CAR T cells in those patients we know are not going to do quite so well with the induction therapy. So there's lots of options there. They're not ready for everyday clinical use, but at least the clinical trials are starting and we're beginning to use those approaches.